Right, it's the top of the hour and we are about to begin. My name is Anafi from ASLM and welcome to session number 14 of our COVID-19 series, a series that we have dedicated to diagnostics in the COVID-19 pandemic. Today we have an interesting subject that for some reason we have left out for quite a while. And today we will be talking about issues of sample referral systems. We have talked about scaling up of testing, but we all know not all this testing that we're doing is decentralized. So sample referral becomes an important subject indeed. Just a few quick logistics before we start. As usual, please you enter your comments and questions into the chat box as the session continues. Today we have an exciting format. We shall start with a few introductory slides and go into a panel discussion. Just want to also mention that due to popular requests for certificates, we have made this possible through our ASLM Academy. On your screen right now is the code that you need to use when you go into the ASLM Academy webpage. Please log in or register as required and use that code on the screen. We will share it again along the course of the session as well. Let me hand over to the moderator of this session today. Her name is Kameko Nichols, a very well-renowned name when it comes to strengthening sample referral systems and logistics systems. Kameko, over to you. Thank you.
Thank you. Hello and welcome everyone. And first off, I'd like to thank ASLM for hosting this session on specimen referrals. This is an important topic, as Anafi mentioned, and one that we have heard repeatedly mentioned, but not with that much detail throughout almost all of the other special COVID sessions. Anafi, could we please pull up the first slide? Next one. Thank you. In any diagnostics network, specimen referrals are key to increasing access to services, as many tests are only offered off-site. Besides increasing access to diagnostics, these systems should adhere to standards of timeliness, quality, and biosafety biosecurity. And under normal or routine circumstances, we look for systems that are cost efficient. Many countries across sub-Saharan Africa have done a remarkable job strengthening their specimen referral systems over the last 5 to 10 years, primarily driven by funding from HIV and TB programs, and more recently also from disease detection, prevention, and surveillance programs. However, most countries still have challenges in the area of integration, ensuring timeliness, quality, and biosafety. Next slide, please. Next, please. Thank you. If we look at the joint external evaluation scores, which assess a country's capacities to prevent, detect, and rapidly respond to public health risks, under the National Laboratory System's capacity to detect disease, it is measured on 4 key criteria, one of which is the specimen referral and transportation system. Across 41 countries in the WHO Afro region, the average score reported was 2.4 out of 5 for specimen referrals. And 80% of those countries scored a 1 to 3. Next slide, please. It is within this context that now countries have to plan for the diagnostics network for COVID testing, with major considerations and implications for where the collection and testing points will be located and whether or not specimen referrals will be involved. The Africa CDC has set targets of 16,000 tests per million population, but currently the continent is at about 1,300. Specimen referrals are not the only solution, of course, but they are critical to reaching these targets. It's important to note that the referral challenges are not unique to Africa. Back in April, the New York Times documented the referral of a nasal swab in the US, traveling about 450 kilometers, which passed through 3 vans, 6 coolers, a plane that had to land mid-flight during a storm, 2 labs to reach its final testing destination. And this was all done by a private lab who has a fleet of vehicles, including 23 airplanes at its disposal. During today's session, we will hear, next slide, please. During today's session, we will hear from country representatives and a multi-country project. Each panelist will give us a brief overview of their specific context, and we will follow that with moderated questions and answers. We would like to hear about each journey, the considerations and the pitfalls, and how to quickly maneuver in the time of a global pandemic to support crucial testing. So without further ado, I will introduce our panelists. For the sake of time, I will introduce all 4 now, and then ask each to give a 5-minute overview. Our first speaker is Maraping, Principal Medical Scientist at the National Health Laboratory, the Ministry of Health in Botswana. Our second speaker is James Kandulu, who's the Deputy Director of Diagnostics at the Ministry of Health in Malawi. Our third and last country panelist is Erin Lunda Shimbemba, the National Coordinator of Pathology and Laboratory Services at the Zambian Ministry of Health, and the Head of Pathology and Microbiology at the University Teaching Hospital. And finally, last but not least, we have Hannah Rabner, the Infectious Disease Health Systems Advisor for the USAID-funded Infectious Disease Detection and Surveillance, or IDDS, project. Next slide, please, and over to you, Maraping.
Good afternoon, everybody. As previously introduced, my name is Maruping, and I am just going to share with you a brief specimen referral system for Botswana. Botswana has a population of 2.1 million people, and we currently have 1 testing facility. It is the National Health Laboratory, and it is currently working on activating. It has activated actually 3 testing sites, especially on the borders, so that we take care of the truck drivers who come in and out of the country. Our healthcare system is a 5-tier system, though it is between 5 and 3, because the lowest is we have 2 combined, like the local and the clinics and the primary hospitals are like confined in one thing. You might be aware that we have a very robust system of HIV program, and as such, we use the existing system now to leverage on it and then accommodate the transport system so that we refer the COVID samples to the testing laboratory. As you can see demonstrated in my slide there, we have home isolation and home quarantines and the local clinics, and we also have our patients put or suspects put in institutional quarantines. Now, when we have patients or suspects in these areas, their samples are collected from their place of quarantine or where their samples are collected, and then they are transported using the already existing transport system between the clinics and the district laboratories. Now, the role of the district laboratory is now to make sure that we have the samples entered into our information patient management system. so that when they reach the testing laboratory, which is the NHL, now the results will go back through the red arrows that you see there. That is the demonstration of the results pathway as they move from the testing laboratory to the health facility. Sometimes we have some patients who are also now kept at the district level, still in the same setup where you have the home isolation, but then it is in a primary hospital, like if it is somebody who is sick. The same protocol of specimen referral system will follow and then go to the testing laboratory, which is the National Health Laboratory. I have included the specimen between the international or regional levels because as part of quality assurance, we send our samples periodically to the WHO regional lab, which is in case the NICD in South Africa. The samples are sent by the existing partnership between Botswana-Harvard partnership and the Ministry of Health. We use the Botswana-Harvard partnership because they have already accredited or certified lab scientists who should be handling samples through the IATA. Now, if you look at the other side of the slide, you have the small red arrows which indicate that the results can also be sent through emails between the health facility and the National Health Laboratories. My next slide is just for people to appreciate the current testing levels in my country as far as the last date was the 29th May 2020. As far as we are concerned, at the moment we have tested 21,216 samples, and with the 21,056 samples negative. And then unfortunately we had one death, and we have a total of 38 positives at the moment. Yeah, thank you very much for listening to me.
Kameko, are you there?
Yes. Next, we are going to move into Zambia's presentation. Aaron, over to you.
Good afternoon, everyone. In Zambia, we have approximately 17.35 million people. And as of the 31st May, we have done 28,248 tests. And the type of specimen that we collect is predominantly nasopharyngeal swabs. In very few instances, we do collect oropharyngeal swabs also. And we have adopted the NAT for both diagnosis and follow-up of our cases. And all specimens are referred for testing. So we have got about 8 testing laboratories, and these are the laboratories that we refer samples to. Next slide. Yeah, and we collect specimens from the mortuaries, health facilities, and both the community. So in the mortuary, routine deaths, we have what we call verbal autopsy. And if there is any exhibition of respiratory symptoms, we swab the routine death so that we test and see whether we are missing any coronavirus in the community or not. And then in health facilities, all health workers are swabbed and tested, as well as inpatients and those who are visiting the hospitals. And this is done mostly at the tertiary level hospitals. And then, of course, the community where we have some mass campaigns where we do screening and targeted testing. as well as point of entry for truck drivers and all those people who do business, who come into Zambia and go out of Zambia. And as you are aware, Zambia is a landlocked country surrounded by 8 countries. So you can imagine the burden that we have in terms of testing at points of entry. Like I said, we have 8 testing laboratories. We have the UTH virology lab, where we are using the real-time PCR machine, ABI 7500, as well as the COVID 6800. At the same UTH, we also are doing gene expert testing, the TB lab. Then we have got Matcha Trust Institution, where the testing is also carried out on the real-time PCR machine. Then the Tropical Diseases Research Center in Ndola, it's also using the real-time PCR machine. Chipata Central Hospital in the Eastern Province, we've got a testing lab utilizing Gene Expert. Chinsari General Hospital in Muchinga Province is also utilizing the Gene Expert. And the University of Zambia Veterinary School is also testing in Lusaka using the real-time PCR. And in Ndola, the Arthur Davison Children's Hospital, where we have a COVID 6800. So these are the 8 testing laboratories that we use. Courier system-wise, the pre-existing courier system is not very much utilized, because what is there now for COVID, it was another province. So we created another emergency transport system so that it can cater for interprovincial courier system. And in terms of return of results, we use email as well as the laboratory information management system. In this case, we are talking of the data lab that we have in some of these hospitals. Thank you very much.
Thank you very much, Aaron. And Hannah, please.
Hi, so thank you to ASLM and to Kameko for inviting IDDS to this panel. Just briefly, to give you an idea of what IDDS does, our main objectives are improving the quality detection real-time surveillance systems under GHSA for existing and emerging pathogens. Again, we focus on surveillance, which I'm not going to even mention at all at this point, and of course on diagnostic network strengthening. And specifically, we have a component where we focus on specimen referral system strengthening. In February, USAID engaged us to support COVID-19 emergency response activities. And this initially focused on specimen transport, training and technical assistance for specimen collection and integrity. We've since expanded to provide technical assistance on molecular diagnostics and of the decentralization of testing, but I'm going to focus on what we have been doing under specimen transport. So we're currently operating in 9 countries, and as you see on your screen, Bangladesh, Philippines, Indonesia, Vietnam, Thailand. And then in Africa, we're focusing on Senegal, Cameroon, Tanzania, and Mali. And so I want to give you a few examples of what we are doing in some of these countries to give you a flavor of the different types of support that we are giving. And I want to say that within each country, we work with the government, WHO, and other partners to determine where gaps are in the specimen referral systems. And what we started initially with was the premise of utilizing our established partnerships with couriers that we had as we were undertaking other activities. That's since changed. And for example, in Bangladesh, They are utilizing a centralized testing system. And as, again, we had initially envisioned using courier, we have now gone to renting additional vehicles for the country and also embedding medical technologists to support the collection surge. Now Bangladesh is going to a decentralization model, and we are preparing to be able to transition. Our support is needed. In the Philippines, we were requested initially to support transfer from regions to Manila via air courier. And then we were rapidly asked to change that to support collection in the southern Philippines, and then transporting those via air to Manila. What we ended up encountering at that point in time was that there were travel bans and commercial travel bans, including not being able to use the air carrier. So we had to very quickly find another solution, and that involved actually reaching out to the military to see if they could support the collection of our specimens and get them transported. We're now in a situation in the Philippines where there has been some decentralization within regions, and we're actually renting vehicles, and we've supported the employment of area coordinators to do the collection and transport. And then another country example is in Cameroon. Again, initially, our support was going to be focused on utilizing an air courier. We were going to be shipping specimens from the regions to Yaoundé. And then further, we were going to be transporting them via vehicle to their final testing lab. Again, having a very fluid situation, we are now transitioning to a decentralized approach, and we are supporting transport from the districts to regional laboratories, and we are renting vehicles to do so. Interestingly, in this mechanism, the government is supporting the collection from the sites to the district, so we are one of many in the chain of getting the specimens to the final testing lab. And just briefly, in Indonesia, we are utilizing an established system, the TV system, to do the transport. So as you see on my next slide, there are key challenges, and I think some of the key challenges is that we have encountered our coordination among partners. I mentioned previously the travel bans, quarantines, and being able to quickly transition to a backup plan. Distance is always a challenge. Wanting to get these specimens within or to the labs within the proper time, especially for remote areas, has been a challenge. We do have situations in some of our countries with security and coping with the fear that is associated with COVID-19. We have, in certain cases, to address that. We are not marking our vehicles, and we're ensuring that our personnel cannot be associated with COVID-19. However, if they're in PPE, that becomes difficult. We have also encountered challenges where we have had staff resign due to the security situations. And to address that, we have tried to have a roster of people that we can quickly call on to be able to take their place. And of course, other challenges include the specimen integrity and the needed commodities to do the transport. If you can only do the transport, but yet the specimen integrity can't be maintained and you don't have the proper commodities, this can be for naught. And then of course, another challenge is as countries are quickly changing from centralization to decentralized models, we have to be very fluid to respond to that. Our lessons learned are when we're working with countries, we really try to plan for now the systems that they have. If they have a molecular platform the molecular platforms that they're using, we have to plan for those, but realizing that a number of countries are trying to employ new models and new mechanisms for testing, so we need to be able to transition fast. And then of course, our other challenges are, our lessons learned are making sure that we ensure quality and safety and just having the flexibility. And so with that, thank you.
Thank you very much, Hannah, and thank you to everyone for those great summaries of specimen referral systems across countries. Now we're going to move on to some questions for the panel. The first question is on this next slide. And you have all mentioned a bit about your country or multiple countries' specimen referral systems. But we would like to know, will the specimen referral system contribute to your national testing targets? And if so, how? And to help answer this, we have some sub-questions in here. Does your country have national testing targets? We mentioned the Pan-African testing targets, but for your country specifically, are there testing targets? And if so, what are they? And approximately how many specimen collection facilities are there in your country? So most countries mentioned how many testing points there are and what types of collection facilities there are. But so we can have an idea of scale, approximately how many facilities are actually collecting specimens. And finally, currently, approximately what percentage of specimens are being referred for testing versus referral of patients or on-site testing? I know that Zambia already answered that, but if we could start with Aaron to answer the rest of those questions, and then we'll go on to Marapeng. Aaron, the first question for you.
Yes. I think the national testing targets, we are also following WHO guidelines, and we haven't yet set our own targets. So this is how we are doing it. And then approximately how many specimen collection facilities? Oh, it's all over Zambia. I can't count. It's all over Zambia. We are collecting specimens from all over the 10 provinces, and it's happening at provincial, at district levels, at community levels. Like I said, we have these mass campaigns of screening and targeted testing. So we are doing it all over the country. And we are not referring any patients, and we are not doing any on-site testing right now. So all we are doing is collecting samples and then sending them to the testing labs.
Thank you. And Marapeng for Botswana? Marapeng, you're on mute. I'm not sure if you're speaking right now.
Oh, sorry, I was on mute, right? Can you hear me?
Yes.
Okay. Can you hear me now?
Yes, we can hear you.
Okay. Okay. At the moment, we do not have any tested targets, because what we have done is we have a responsive mechanism whereby our testing moves towards, maybe if we have maybe detected a case in a district, then we would have a targeted testing towards that particular district. So, and this makes us to also be able to have facilities that are ready to test samples or collect samples anywhere in the country. And as such, I do not have any specific numbers to say we have so many facilities in our country. But what I can confirm is we are everywhere in the country to do the collection of specimens. But now, the testing facility, like I mentioned, we have the National Health Laboratory, and then last week it activated 2 more testing sites, especially in the border areas, to take care of the truck drivers. And we do not do any patients or test them on site. We collect specimens and then refer them to to the testing laboratory. Thank you.
Thank you very much, Marping. Hannah, I'm not sure if you have anything to add from any of the experiences that IDDS has working across countries, maybe in particular, the amount of specimens that are being referred versus specimens that are being generated on site.
Sure. I can't say for all of the countries that they do have testing targets. Some do, but specific to our support, we are on a daily basis in the countries that we are doing the transport. We are, I think, between collecting about we might have up to 30, 40 unique sites. And on a weekly average, we're supporting the transport of, I think, around, in one country, 300 to 400 specimens. But again, our support is limited to specific regions, and we're one partner within many. So I believe in our countries, most of the specimens are being referred versus the patient, but I'd have to check on the particular countries.
Thank you, everyone. The next question, just getting more specifically into some of the details of each specimen referral system in each country. The next question is, with swabs, we know they must be triple packaged and kept cool and reach the testing laboratory within 72 hours of collection. Some of you mentioned or alluded to some challenges with this. But could you discuss any challenges meeting timeliness, biosafety, and quality goals? For example, are the specimens reaching the testing lab within 72 hours, in good quality? If not, what are the issues? And are the specimens properly triple packaged? So to start with, I'd like to ask Maraping this question. Maraping?
Is it me?
Maraping?
Oh.
Okay, let's start with Aaron.
Okay.
Thank you.
72 hours, I think we are trying, but not in most instances. And actually I can say most instances we are managing to transport our samples within 72 hours. What is the challenge is the testing. We have challenges in reagents because of the lockdowns of where these reagents are coming from. This has been a challenge such that we have accumulated a backlog. And after 72 hours of storing these samples, I'm sure the integrity of the samples is compromised. So we are still discussing on whether to proceed testing the samples that we collected 4 weeks ago or just to discard them. Maybe from this meeting, some member countries have got an experience which they can share with us so that we move forward with this. In terms of delivering samples within 72 hours, we are managing that. The challenge is the testing because of lack of reagents. Thank you.
Thank you very much, Aaron. Maraping, do you have any experiences to share on biosafety or quality or timeliness from Botswana?
Hello, can you hear me?
Yes, we can hear you.
Okay, we do not experience any challenges as far as receiving the samples in the laboratory within their 72 hours.
Okay, great. Any challenges with the packaging of the specimens when you receive them, or any other quality issues?
We do not experience a lot of challenges. One of the few challenges that is worth sharing is the issue of the quality of the viral transport media. There was a batch that we had seen that it had discoloration before use. So that was the only challenge that we had. Besides, a few of them had a problem with the lid, the quality of the lid. So it was not easy to tightly close. So that is one of the challenges that we have as far as the viral transport media is concerned. Otherwise, the challenge that we have is the challenge that we have as far as personnel is concerned. Of course, when we deal with COVID-19, there is a lot of fear amongst everybody, including the persons who ship the samples to the laboratory, as well as some of the laboratory persons who work within the other departments of the laboratory. So of course, fear is one of the greatest challenges that we really have to work on in the healthcare system. Yeah.
And thank you, Marapeng. Also, just to follow up to what you just said in terms of fear, especially with transporters or with lab staff, how have you been able to, or have you been able to overcome this? How have you dealt with that?
Yeah. Yeah, most of, usually fear comes when people do not have, it comes because of beliefs. And we have benefited from engaging with personnel, understanding where their fear comes in, and of course, targeting our education to address such issues. Some of the fears, most of the time, will be associated with maybe biosafety or biosecurity. And then when you do targeted training towards this topic, you realize that actually the fear just goes away tremendously. Yeah. So education helps take away the fear.
Okay, thank you very much, Marapeng. Hannah, anything to add from the countries that IDDS is working across?
Sure. So in the countries where we are transporting from the collection site to the testing laboratory, the majority of our samples are being transported within 24 hours and certainly within 48. So we are meeting, the timeliness metric. Where this is getting a little bit more complicated is in the countries where we are one part of the transport. And we do have several countries now, and I mentioned one earlier, Cameroon, but also in the systems that we're setting up in Mali and one other country where they're either going to be transported by another mechanism at one part, either at the beginning or the end of the chain. And so in those situations, we're just starting, but we have realized that this issue of getting the specimens there within 72 hours is going to be a challenge in maintaining the the proper temperature. So we're working with the governments and the partners to do things like put temperature monitors and make sure that we can at least somehow track if they are arriving with the proper temperature maintained. But we do recognize that's going to be a challenge for us. And so when we're doing the direct transport, we do capture whether the specimen was rejected or not. And so far, that has been, I think we've had, of all the specimens that we have collected, maybe 1 or 2 rejections.
Great, thank you. And I just wanted to welcome to the call James Kandulu. We introduced him earlier, but unfortunately, I think he was having connectivity problems up in northern Malawi. So James, If you're here now, I just wanted to give you the opportunity to tell us a bit about Malawi's specimen referral system for COVID testing.
Thank you so much, Kameko. You can hear me?
We
Can you hear me, Kameko?
We can hear you. I think the connection is a bit
Yeah,
spotty.
we can. Thank you.
Sorry for the poor connectivity. So, your question again? Kameko, have I lost you again?
No, I can hear you.
Okay, so what do you want me to say?
The overview of Malawi's specimen referral system.
Okay, thank you so much for the chance, and sorry to everybody for missing the presentation. However, I hope the slides will be shared. Malawi, we do have radars for health who are always transporting lab specimens to the testing laboratories. But for COVID-19, they have not yet started transporting the samples. However, a training was conducted, that's the biosafety training with riders, prevent them to start transporting posts. The current system in Malawi is that we have district response teams that go to residents of the suspected patients. They collect the sample from there, and then they bring it to the hospital. That is for every district hospital has got its own rapid response team. It is now from the hospital that they transport the specimens to the testing laboratories. This is where we want now to engage the riders the moment we are ready to do so. But because of the need to transport the samples with cold chain systems, we are still working on that one. The moment we are done, the riders for health will be involved in the transportation. Currently, we are just using the utility as well as the ambulance vehicles to transport the specimens to the testing laboratories. In brief, that's how it is happening in Malawi.
Okay, thank you very much.
Kameko, I'm done.
Thank you.
Hello?
And yes, everyone will get a copy of the slides, so they will be able to see the overview that you prepared.
Thank you.
On slides. So at this point, we wanted to also make sure to include questions from the audience. And one question was actually sent ahead of time. And that question comes from David Ocheng. And this question we'll first pose to James. And the question, I'm paraphrasing a bit, but the question is how you balance between the decentralization of testing and improving the specimen referral system. How do you balance these two things when we're thinking about COVID testing? James, are you still with us? Okay, let's move to Marping. Marping, same question. How do you think about the balance between decentralization of testing? You mentioned that Botswana was mainly doing testing out of one laboratory and has added two recently. But how do you balance the decentralization of testing with strengthening specimen referrals? Marping?
Hello, can you hear me?
Yes, we can hear you.
Yes, I missed the question because sorry, I have poor connectivity. Can you come again, please? Sorry.
Yes. We had a question from the audience about the balance between decentralization of testing and improving or strengthening specimen referrals. So whether or not you have a more centralized testing model and more referrals, or whether you aim for decentralized testing with a different type of referral. But how is Botswana thinking about those trade-offs?
Yeah, it's of course, we had to look at the issue of the turnaround time, which is a challenge that is attributed to having only one lab doing the testing. As such, we are fully fledged on ensuring that we have at least decentralized testing, so that we have at least the quality of the samples arriving in the laboratory on time, and also having the results or the samples tested on time, and for the country to respond appropriately because the results are given on timely. You will agree with me that you want to test, and you want to do that within the shortest time available, so that the policy is implemented quickly and as soon as possible. So decentralization is one area that my government is very serious about it, and we take it very, very serious because we want to improve on testing. It is also going to benefit on the issue of specimen referral system.
Okay, thank you. The next question comes from Ochieng Edwin, and this question is for Aaron. This is going back a bit to the quality of the specimens, but could you comment on the rate of specimen rejections due to poor quality? And how is this feedback given to the collection centers?
Yes, like I said, right now we haven't started rejecting any samples yet, and we are still testing. But the question that we are asking ourselves is that, is the integrity of these samples that we collected, for example, 3 or 4 weeks ago, still intact, or the samples have been compromised? And in terms of results retained, we are using 2 models, and the one that is mostly used is the email system that we are using. Yeah, because where these samples are coming from, the laboratory information management system that we have is not there. It's mostly in these provincial health hospitals. So we are using the email, and then within the hospitals, we are also using the laboratory information management system to inform the clinicians of the results of the COVID-19.
Great, thank you. And just a follow-up question also for you, Aaron, as well. Is there any plan in the future to use the pre-existing specimen referral system, to start to use that system as well, in addition to the system that you've put in place specifically for COVID?
Yes, right now we have a very strong referral system in provinces because of the HIV and the TB programs. And what we are doing is to make what we are calling an integrated sample referral system. And this is the system that is now going to incorporate interprovincial sample referral system, which we don't have right now. We have intraprovincial, but interprovincial is the one that was lacking, and that's why we couldn't basically use the existing sample referral system that is there. We are using it within the province, but between provinces, we had to come up with a different system.
Okay, thank you. We had another couple of questions. There's one coming from Brianna Kiernan, and this question's for any of the panelists. In countries where you work, are there any opinions or any evaluations done on transport of dry swabs from referral sites to testing sites? Have there been any evaluations done comparing dry swabs to swabs in transport media?
In Zambia, we haven't done anything. We are using the VTM transported swabs.
Okay, thank you.
Okay, in Botswana, we have not done any work on the dry swab. We are currently using the viral transport media. Thank you.
Thank you.
In all of our countries, we are using swabs and viral transport media.
Okay, great, thank you. Another question, Hannah, for you. Going back to how you mentioned that in some countries, IDDS is tracking the turnaround time, tracking results. How are you able to do that in countries? We know that tracking specimens can be challenging even during routine circumstances, but is there anything that you're doing that you could share with the group that's working in terms of specimen or result tracking?
So I want to clarify, in most of the cases, we are not doing the result tracking. We are tracking basically everything to the collection site, and time to the laboratory to be tested. In this case, for us and due to our requirements, we have basically another system where we, for the project, are collecting through an Excel spreadsheet, and we literally track every specimen. That being said, we do know that there are other mechanisms within country to track the specimens. I do want to say, in the case of Indonesia, and I think this is a fairly good model, we are initiating work with the TB system. There's a TB specimen tracking system, and we're just starting this work, so I would say stay tuned, but we're working to expand the system in different sites, and also to be able to incorporate the COVID-19 specimens, so you can do the entire tracking from collection to return of results. But that's just starting.
Great, thank you. And I wanted to ask our next question actually to another participant who hopefully is on the call, Anthony Ahumimbe. I probably did not pronounce that correctly, from the Nigerian CDC. Anthony unfortunately was not able to join the panel today, but I was hearing more about the Nigerian experience with specimen referrals and heard about some of the different systems that were used depending on the states in Nigeria. And I was hoping that, Anthony, you could share a brief summary of your experience so far with specimen referrals and any quick challenges or advice for the group. Oh, Anthony, are you here? I see you, but I think you're on mute.
Hello, can you hear me?
Yes, we can now. Thank you.
Thank you so much. So I'll just say that the Nigerian experience in terms of sample referral for COVID has been a very rich one. Before COVID, we had some parallel sample transportation systems. We had the NCDC focused sample transportation system. That's the sample transportation system that was managed by the Nigerian Center for Disease Control, which was effectively targeted at epidemic-prone diseases. We also had a parallel system that was being run through the PEPFAR program that was focused on the TB, malaria, and HIV initiative. And then you also will remember that we also had a multi-agency group that was targeting activities under the eradication of polio, which also had to do with WHO and UNICEF coming together to help us transport or refer samples for polio testing. But when COVID broke, it became very necessary to get these teams to work together. So the experiences from these different teams came to play, and we had to meet to discuss how to leverage the capacities and the core competencies of these different groups to make sure that we bring them together to work on sample referral and transportation in Nigeria. And if you can remember, it's quite a big country with 36 plus 7 states. And because of the size, we knew we had an enormous challenge. The NCDC transport system had been deployed very effectively in managing sample transportation between the states. So for COVID, we kept them helping us with interstate sample transportation. And just to note that at the onset, when we had our first case, we actually had 5 labs that had PCR capacity, molecular capacity for testing for COVID. And samples now had to be moved from one state to the other to where these sites were located. But as we kept working on COVID, and then we had increased transmission after our first case, which was sometime in February, 27 February to be precise, the caseload increased. There were particular states that had a lot of cases, and you could recall places like Lagos State, which is a big cosmopolitan state, Kano State, Kaduna State, Oyo State. These are big states with
Anthony, we've lost you. Anthony, are you still there?
His mic is off now. I think we lost him.
Okay. Okay. Unfortunately, we are getting close to time. This was a great discussion today, and I'm sure there are a lot of follow-ups that would be great to hear from countries who were panelists, and also countries that we weren't able to get on the panel today. But it was a very rich discussion, and we hope that everyone enjoyed and learned from it. And I'd like to give the last couple of minutes of the call to the panelists to just give a 30-second very soundbite of advice to the group before we end. So if I could ask Hannah first this time.
Sure, I think my quick soundbite would be to plan for what you have now, the situation that you have now, but be flexible enough to also be thinking about the scheme that you want to have in the future, how you can be more sustainable with it, and then just be very, very flexible, because we do not know what's happening with this disease, and things change on a daily basis.
Great, thank you, Hannah. And Aaron?
Yes. I think the biggest weapon that we have is integration. We need to integrate. We have got the capacity, We have got the capacity in terms of human resource, equipment is there. So we need to integrate things so that we can be more cost effective and efficient. Thank you.
Thank you, Aaron. Great advice. And Maraping?
Oh, thank you very much. Mine is for, it's just to encourage people to take advantage of the fight that we are in, and just be strong and improve testing, so that we can detect the virus and be able to fight it.
Okay, thank you very much. And Anthony, if you're there, I'll give you a quick 30 seconds to give your last piece of advice since you were cut off. Okay, unfortunately, I think the connection has gone bad, but thank you to everyone today, to the panelists, to everyone who joined. I think that we learned today that there are many ways to support increased access to testing through specimen referrals in ways that are safe, quality controlled, and quick. But there's no one-size-fits-all model, and there may even need to be more than one model in a country, which was mentioned by multiple panelists. But it's important to share and learn amongst countries, and thank you again to ASLM for giving us the platform to do so today. If you're looking for additional resources on specimen referrals, please visit the Specimen Referral Toolkit, which is online, and it has a collection of journal articles, guidelines, monitoring and evaluation tools, training materials, etc. It's not disease specific. It has tools and resources for all different types of diseases and for integrated systems. And that is also included in the presentation that you'll see. And with that, I'll close and hand back over to Anafi.
Thank you, Kameko, and thank you to our panelists for the wonderful discussion. We greatly appreciate you making time, leaving off the great work that you need to do in your countries. And we hope we have learned quite a lot from this discussion. We acknowledge the lot of questions that are in there. As usual, we are going to compile these and bring this to you as we share the slides as well as the recording. Also want to mention a few announcements to our country teams. We are planning something that may be of interest to you, as we discussed in our last face-to-face meeting last year around monitoring and evaluation. So we are now at a stage where I think we will be able to start our sub-community of practice. So we call upon to you to start thinking who among us, your teams, could be available to participate in this important subject, where we want to monitor our labs strengthening systems, particularly for viral load, EID, and TB. But this time we want to focus on monitoring and evaluation of what we are doing to see where we are going. So watch out for that email communication in the next few days that is coming through. Secondly, as I mentioned earlier on, those who need certificates for attendance, please go to the ASLM Academy, try to log in or register if you haven't, and then go to session number 14, follow the instructions that are there, and you should be able to download your certificate. Our next session is the usual waste management session on Thursday for the month of June, where we are going to bring our colleagues from the Global Fund to share with us what they have on offer, what is it that they are supporting on healthcare waste management, and hopefully we get you joining again. Watch out for the announcement immediately after this call. Till we meet again, thank you and goodbye.